Good afternoon and welcome to the Flint Community Webinar, your community resource every Friday at noon. We're excited to be here in partnership with a lot of great partners today, and we've got a really great session for you today. We've brought some excellent speakers here to talk to you a little bit about various different topics. We're going to start off a little bit talking about mental health and opiate use disorder, and we're going to go talk to Dr. Danik a little bit about what opiate use disorder looks like in the hospital. Nurse T and Dr. Gordon are going to help us with that discussion, and then we're going to go back to an old, not necessarily friends, but we're going to talk a little bit about COVID again. Want to make sure we're always updating you in the community about COVID and what's new to know and what we should be thinking about. And we've got some really great experts in Dr. Lipton and Dr. Vega coming to talk to us about that. Dr. Haggerty is going to take us away at the end and talk to us a little bit about how COVID has been impacting the Flint registry. So we've got a bunch of great people here to talk to us today, and we're ready to get into it. So we'll bring up Dr. Danik, and if Nurse T and Dr. Gordon are here, we'd love to hear what your thoughts are on sort of opiate use disorder and what that looks like in the inpatient hospital setting.
Hi, everybody. Hi. Introducing Dr. Danik. He's going to take away his presentation, and we'll come in and ask questions later.
That's great. How's everyone doing? Do you want me to get started?
Absolutely. Thank you so much for being with us today.
Sure. Well, I think this is a great community outreach program. And the biggest part of opioid use disorder is trying to find an opportunity when you can start trying to treat it. People all know individuals who are suffering from it, but when someone comes into the hospital for something else and you can try to diagnose this opioid use disorder, that's the perfect time when someone's thinking about their morbidity and mortality to really say, you know what, this might be the time where we can work on this as well. And I have nothing to disclose. I got to figure out how I can move my slides here. There we go. And I'm ex-waivered. I'm an anesthesiologist. I'm not an addictionologist yet, but I'm certified with all these different organizations. And we all know that this national disease process is extremely active within Flint. We know that more people are dying in Flint even since COVID because they can't get to treatment. We also know that if you start treatment in the hospitals, there's a better chance that people can stay on the right track. And that's what we try to do with our B team. People will say, why do you call it a B team? B is for buprenorphine. And it keeps people away from thinking that you're the A team, because we're not the best. We're just trying to figure out a way to help everyone. So we're trying to save lives, reduce transmissions, decrease criminal behavior, trying to keep people in treatment, reduce all these increased risk for human trafficking. And we're looking to try to improve physical and mental health. For years, we've saying, okay, doctors and nurses, you need to fill the gap. We're going to start doing X waivers. Okay, we're going to do notice of intents, and everyone's going to learn how to do it. But what I found was that no one was doing it. And that was disrupt, everyone had an X waiver, but no one was really writing for buprenorphine. Now there's a new law in the omnibus package that came through, and you don't even need an X waiver or a notice of intent. So more people should start treating. I'm afraid that people are still scared of it. And that's my goal with the B team as well, is to increase this education to both residents, medical students, nurses, and everyone else. So the founding members were myself, Melissa Murphy, Aaron Rubio, Brett Smith, Rebecca Corbett. And we've defined this as ASAM has as a chronic relapsing disease. And I think you need three things to really help get control of this disease. You need medication. You need time to have the neural networks repair. You need behavioral therapy to cope with those demons and that inability to manage control issues. And then you need to connect with others so that you have a new way to start living life. I always tell people when I'm meeting them in the hospital, I said, your willpower, it's not your fault. There's a giant genetic component to opioid use disorder. And I tell them with diabetes, you take medications for your diabetes and you keep it under control. But ultimately, how many people take their medications correctly? And that's one of the big things that we're trying to improve with our community partners, is trying to learn that discipline to stay on the right path. And to maintain that discipline, you need a lot of professional help. You need motivational interviewers, you need cognitive and behavioral therapy, you need psychiatry, you need counseling, you need Narcotics Anonymous. And most of the time, people who want help can get it, but staying motivated is the biggest issue. I show this picture to almost all of my patients. I show them the neural pathways because I have 15 minutes. I'm not going to get into all the neural pathways, but I let them know that it's a true disease. And even if they don't have a background in science, they understand that there's different pathways in the brain that are diseased and that we can try to help rewire those with the correct medication. I also hammer home the point that this is a spiritual and consciousness disease as well. And it doesn't matter whether it's Christian, Muslim, Jewish, Hindu, Mother Earth, quantum mechanics. There's something greater than us as humans, if you will. And that's what's unique to each person. When you're laying in bed at night and you can lie to yourself, talk to yourself, dream, reflect, that's what we're trying to work on. And building that is extremely important. And it's not based on religion per se, because most people suffering from opioid use disorder already have a warped sense of religion. But many have some sort of faith, and we try to tap into that. It's a spiritual disease as much as a mental disease. So I started this by a B team IRB protocol, had to get a ton of support from pharmacy, nursing, case management, had to get new policies. And most people thought we were just an AMA service, just to keep people from leaving the hospital, AMA. And it was really a giant opportunity for stigma reduction. And so we had to create these minimum standards. So we formulated this over about a 6-month period of time, and we found ways for the whole hospital to communicate with us. Initially, I had my cell phone number given out to all my patients, but my wife quickly put an end to that because they were calling it all the time. Now I work through some peer recovery coaches. Case management support is huge. Trying to get the social setting together is extremely important. My main partner is UCAN, and he helps link into all of our other community partners here. New Pass, Odyssey House, Genesee Health System, Sacred Heart, Salvation Army, Serenity House. I mean, they all do a phenomenal job of trying to give services to people who want them. And then we also use the Hope Network and Meridian, and there's so many different things out there, but linking them to individuals is essential. Know More About Addiction is part of the Genesee County Substance Use Prevention Program. Kelly Ainsworth does a great job with this, promoting it as well. And this website's perfect for everyone who's looking for resources. Also said, well, if we're doing this, I might as well start a rotation for residents, psych fellows, and medical students so that they can follow me around and learn this, because they are the next generation. I need them to be comfortable. There should be no reason for a B team. Just like hypertension or diabetes, every physician and nurse practitioner or PA should be able to treat this. It's not that complex. It does take time, but we just need to change the culture of this is some little specialized thing. It's something that everyone can get comfortable with, and we're going to have to move that mark over a decade or so. It's not very easy, but it's something that my goal is to teach everyone that comes in my hospital. We're always looking at maps. We know how to diagnose it by confirming at least the DSM-5 criteria. We go through this with each of the patients, and we make sure that they're taking longer than desired. Have they had social issues or problems and cravings? Do they have tolerance? So we look at all the science behind it and go through and make sure that we're actually meeting these criteria. Then we look to see if they're withdrawing. And a lot of times patients start withdrawing in the hospital because they're in for something else. And trying to identify that instead of just treating them with some morphine or fentanyl or giving them Norcos on a bus pass, that's really what was occurring. That was one of the main reasons I started this. I saw so many people just being treated with opioids in the hospital for no reason, just so that they would remain quiet. And this happens throughout the nation. It's not just anywhere in the Flint, Michigan. So we're fixing that and giving different opportunities. And sometimes, I had to teach everyone how to treat withdrawals. And if you're an addiction medicine specialist, it's simple, but they might not be ready for buprenorphine or methadone or anything else like that. So there's other medications that you can use, and you have to be careful with the benzodiazepines and phenobarbital, but you can get into the real nuances on the rotation. One of the big things is that we always have this idea of what we want our patients to be. And the medical students, the residents, and our B team as a whole had to realize that not everyone is going to go to college, have a wonderful family, a little white picket fence in a suburban neighborhood. there's different issues for everyone depending on where they're growing up, what their genetic composition is, and everyone is still very special, but we have to find out what are their goals, what is something a success for them. And sometimes success is not using opioids for a day. Sometimes success is not wanting to end your life for a week. Maybe it's just trying to stay clean for 30 days. Sometimes those little successes are important. And so one of our big education parts is, trying not to harm yourself. That harm reduction strategy is extremely important. And these are the stages of change we go through with all of our patients, or try to figure out where they're at. Different protocols are here. The one thing I always tell our team to watch out for is fentanyl. And I put this picture up here because in Flint, there's really no heroin anymore. It's fentanyl. And you think you're getting heroin, but you're getting heroin with mostly fentanyl. And we've had a lot of people overdose on that. It's very scary. And so we also, when we start to try to treat them, we don't want to put them into precipitated withdrawal. And that can be a giant problem because then they never want to go back to treatment with medications because it gives them a bad taste of rehabilitation. And precipitated withdrawal is basically if someone isn't withdrawing yet, then you try to treat them and it makes them go into withdrawal immediately because it kicks off the drug off the receptors. So then we get into the deep history, and this is where the whole community really is involved. We obviously use buprenorphine here. We use buprenorphine because it's safer and it doesn't cause a respiratory depression like all those other medications do. And we have certain parameters where we use it, and everyone's taught that. When we set up algorithms, and this came from Seton Dell in Texas. They had a B team, the first B team in the nation, and they helped develop this. And I said on the national level to help make sure that we could roll this out to community resources. And then we go through all their living situations, their vehicles, do they have children that we have to talk about, education, sexual history, any type of substance abuse. And other things that we have to watch out for is, syringe service programs, making sure that we can help people in that direction if they're not ready to stop. And then we also want to talk to the other hospitals in the area, McLaren and Hurley. Okay, you were here. Let's try to communicate. Let's try to set you up with someone else. What might be better for you? Behavioral health is a giant part of this, and making sure we link people up with the community of mental health is very important. And that's why we're happy to have psychology fellows on board too, because they really can help dive into it. We also do Hep C, Hep B, HIV, ask those tough questions, and we can refer to, Brian Boston at the Wellness Aid Service areas. There's always different people in this community that want to help. It's just patients need to know how to get there. We do physical exams, we do urine drug screens, and then we want to ultimately link them with a peer recovery coach, whether it's from UCAN, New Path, Serenity House. That's when someone comes into the hospital, says, hey, we've been through this too, and we're going to help start this treatment plan and follow you through to the next setting. So I'm almost getting to some time. I see that I'm getting to about 15 minutes, but we're also trying to use digital prescription therapy out there. And that's things that people can use on their phones so that can kind of keep them into their therapy. We're trying to get that tracking going on. Patients have to be motivated for that kind of a thing, and they need to have good family support systems. Sometimes the goal is just to find a place to live, and that's where we have to communicate with Sober House, My Brother's Keeper, and stuff like that. But ultimately, we try to blend into the idea that they can get better if we stick with the program. I can get into other things now, but this might be a good time for questions because there's a lot more addiction medicine stuff that can come in, but.
That was a great presentation, Dr. Danik. And I know one thing when working in the recovery room, we have when patients come in and they are already on treatment plans, or they are on addictive substances or going through opiate use disorder, they're worried about being treated in the hospital. So can we kind of go into different pain modalities that we use when they come through for a surgery?
Mm-hmm.
Yeah, so that's a great question. So 5 years ago, we used to try to tell people to wean off of the buprenorphine or Suboxone before surgery. We don't do that anymore. take your Suboxone all the way up and your methadone through surgery. That's important. Talk to your prescriber and let them know that the new guidelines are to stay on that medication. And then you also tell the anesthesia and surgical team that you're on it. We have to use higher doses of acute pain medications, and that's okay. We have to use different things like nerve blocks, but fentanyl and Dilaudid for surgical acute pain is okay. You know, opioids are okay in that situation. The moral of the story, and this comes from University of Michigan, there's actually a thing here. Yep, that's the one from Rewrite the Script. Basically, you can stay on it. And that's what I want you to do.
Okay, and then we have another question out. What is the difference between fentanyl and heroin?
So fentanyl, fentanyl has is more lipophilic. So that means it's more fat loving and gets into the system faster and holds tighter to the mu receptor, if you will. And it's a synthetic drug that's made by pharmaceutical companies, but the ones that we hear about that are mostly on the streets are ones that are made in labs either in Mexico, China, and shipped across the border. So it's a chemical very similar to heroin that binds the receptors, and it binds for a little bit longer and stronger.
Yes.
Hi, Dr. Danik. I'm Tarnisa. I'm from Hurley Medical Center. I'm the patient resource and community advocate. As well, I worked at Flint Odyssey House as a substance abuse detox nurse.
Oh my goodness.
So my question is coming from the perspective of the community and a concern and a question that they would have. I know as far as we changed the name from a drug addiction to opiate use disorder, which is good because it helped destigmatize. And it also encourages our community residents to look at this as an issue that they can receive help for. But on the other side, we have a lot of community residents that would seek more help for this if they were not treated as though they were criminals for having this type of bad lifestyle choice. So how do we encourage our community residents to come forward? Because if we see, like in the African American community, we can see the death rates for this has increased. And I'm believing that is because they are afraid to come forward and say, I need help. So one thing that's very instrumental, because I love all of the programs and I love everything that's in place, because Hurley has this in place as well. And I'm glad that we are coming forward and we are talking about it and we have all of the resources. But so many times patients don't want to come forward because of the fear that they're not going to become as where it's a disorder and it needs help. They're like, I'm not going because they're going to treat me like I'm a criminal, I'm a drug addict, and I'm going to be in jail and I'm not going to get any help.
Dr. Danik,
I know that was a lot, but how? Yeah.
And Dr. Danik, I want to, there's a space in which primary care doctors also have some culpability here, right? There is this space where we get really nervous about people on opioid medications, and our policies in primary care offices can be really complicated for people who need opioids maybe to navigate. And so there's a part of the culture where this gets really difficult, like Nurse T was alluding to, where we play into it a little bit. So I love if in, the 3 to 5 minutes we have left, if you could try to get at some of that. I know it's a huge topic, but I think it's really important.
Yeah, so I think it has to start at the individual local levels with people like us on the phone or on the Zoom call. There's no policy that can be written to stop racism. There's no policy that can be written to stop opioid use disorder stigma reduction. It comes from people living it and spreading it as much as they can. And that's honestly what I think is necessary here. every student I come in, every nurse we touch at the hospital, they understand that it's a different person trying to help them. Can you imagine having six patients, and the one is always yelling and screaming and upset, and because he wants pain medication, but you realize, you know what, he has a disease process. And I literally will take 5 to 10 minutes to talk to them. And by the time I'm done with that conversation, those people are looking at things a little bit differently. We have to have those individual conversations. And I think that's really the only way we're going to move the mark. I have this dream of policy changes where everyone says, this is what we're going to do. It's okay. Let's get everyone treated. But ultimately it happens at the individual level. And as us, I think we're all educators on here. We have to just kind of teach this new group coming forward. For primary care physicians, a lot, I'm on the PHO board as well, and we've educated all the PCPs and family docs, and we offer a consult service to them. Dr. Masternick at Insight as well says, you know what, send them to me. I know it might be a little bit difficult, but we'll take your patient, kind of get a plan together, and then send it back so that you can manage it. And I think that's ultimately one of the best ways as a community to deal with this. The other problem, and one of the most difficult things, is some of the rehabilitation centers. I know everyone wants to go to the place on the lake where they teach you how to meditate and have yoga and pay $25,000 a month. But in our communities, it's tough. And we have these individuals that are working so hard. I mean, these are saints at the rehabilitation centers trying to help all of God's children. And they just, trying to make sure that those are safe areas and trying to keep the drugs out of those areas is really important too. So we want to make all of our rehabilitation centers as nice as possible so that we want to send our family members there as well. And so that's one of the tough things. I know there's a lot of people working on it to try to use the funds in the right direction. So that's the best thing we can do to help people come out and talk about it. Because when you go to those centers, you say, you want someone to come back, have success, and then you bring the next person in. So I want people to say, come to the B team so that they get a little bit better and they spread the word.
Thank you so much, Dr. Danik. Thank you so much, Nurse T and Dr. Gordon. We really appreciate you're always in the community bringing us trusted information. Thank you so much to all of you and your expertise. This is a really important issue that we'll be bringing back up. You've seen us kind of talk about mental health throughout the year, and we would love to have you back on, Dr. Danik. Thank you so much for your expertise. We're going to pivot a little bit. We've talked a lot about infectious diseases in the new year. We've talked a little bit about RSV. We talked a little bit about flu and what COVID is doing. I really want us to think a little bit about what COVID is doing right now in the new year. We haven't had a lot of conversations around that, and I'd like for our experts, Dr. Vega and Dr. Lipton, to talk to us a little bit about what we're seeing with COVID and what we should be thinking about.
Hi, thank you for having us, and it's always great to be involved in these talk conversations with the community and share some new information. I know that all of us are already kind of tired of talking about COVID-19. Everyone is this is still ongoing, and the thing is that the virus continue to change, and with those changes, there are new concerns that may arise, and also with the season and the other viruses that circulate during the different seasons, we can have multiple infections. So COVID, you can have SARS-CoV-2 and other viruses at the same time, and it gets a little bit complicated. Today, we're gonna talk a little bit about the importance of keeping a surveillance on the evolution of the virus and how it has changed through time that makes it still relevant to keep informed and to be protected about these new variants that are coming up. I prepare a presentation just to guide the discussion, and always like to have some kind of visual. So let me just share the screen and see if we can wait. Hold on a second. Okay, I don't know if you which one you can see. Hold on a second. Let me see. Share the screen here. Share, and I'm gonna.
Oh, we see your Zoom.
Yep, we can see your screen now. The
Okay,
spike.
perfect.
Yep.
You see the presentation?
Yes.
Okay. So what you can see here, sorry for the background noise there, is the structure of the virus and why it gets its name, coronavirus. And this is a very simple illustration and about the structure, that within that viral structure has some material that encode information that is vital for the function of the virus. It's about 27 proteins that are codified in the genomic material that is transported by this virus inside the virus. And these proteins are the ones that are responsible for making the structure and also allow the virus to replicate within our cells. I'm going to be talking more about this protein here known as the spike protein, that is actually the one in the surface that is the specific protein that make contact with a protein that we have in our cells and is the key to enter into our cells. So that protein, that spike protein, interacts with the ACE2 protein in the surface of our cells. Once the virus get inside, that material that encodes those 27 proteins get inside our cells and replicate and hijack the machinery that is in our cells to produce proteins. And once the viral proteins are produced in the cell, more particles or more viral particles are generated within the cell. So it's like a clone. So it's like replicating, multiplying within the cell. And once those new viral particles are replicated, then send a signal that allows the viral particles to get out and infect other cells. Or actually, when we cough or we are talking, we can pass the virus to other people. And that the accumulation of those viruses in our system and due to the replication of it is what caused the disease that we know as a COVID-19. During that replication process, the proteins that are responsible for replicating the material, the genetic material of the virus, make a lot of mistakes, and they are not very good to repair those mistakes. And those mistakes are accumulated in the structure of the protein as something that we know as mutations. Let me get the pointer. Known as mutations. So those mutations change the structure of the protein in a way that makes it more able to interact with the ACE protein in the surface of our cells. So it can interact better, but also change the structure of the protein so that the antibodies that we produce to fight the virus can interact with the protein or recognize that protein less. And the accumulation of those mutations is what creates the different variants that you have heard talk about in the news and in the press everywhere. You heard about the variant Alpha, first identified in UK, then the Beta in South Africa, Gamma in Brazil, Delta in India, and now we have the Omicron. And what you can see is that when there are accumulation of mutations in this virus and generate these new variants, their properties also change, like how transmissible it is or how well it can infect others. And you can see that some variants are less transmissible than others, where the Omicron, for example, is the one that has the highest level of transmission. Also, you can see that the Delta has the propensity to have more severe symptoms, where the Omicron is possible to get into the severe reinfection and vaccine effectiveness. So once those changes happen, as I was explaining before, it changes the structure so that the antibodies that we produce that were induced by the vaccine, now the efficiency of it is reduced by the accumulation of those mutations. So that means that our immune system cannot recognize it. So as we go through this pandemic and people get infected, there is more chances of accumulating mutation and generate different forms of the SARS-CoV-2 variant. And it's important to maintain this in perspective, because it's not only during the time of infection. We are starting to understand what long COVID means and the impact that it has in different systems, from the lungs to the brain and the central nervous system, either with affecting the function of the brain and then expressing into psychiatry or behavioral problems to the individual. So it's very important to know that you don't have to get into the severe symptoms in order to develop what we start to know as long COVID-19. And to give a little bit of perspective of what is happening in Michigan, Dr. Lipton is going to talk about what we have been finding in using this surveillance in actually mainly in West Michigan. Dr. Lipton.
Thank you, Irving. So we have a program that is funded through the Michigan Department of Health and Human Services to collect samples from different clinics, most of which are in Michigan. We're getting in West Michigan, some of which are in Lansing. And our goal is to collect samples from people who are positive. Typically, we are testing people. They're going to clinics and using an antigen test, the kind of over-the-counter test that you can get from at home from CVS or Walgreens, wherever you get it. And then if that's confirmed at the clinic, we get an additional sample that we collect using a kit that we had developed for doing testing back in 2020. And we're repurposing those for this variant genomic variant sequencing project. As you look through the list of all these variants, and I know there's a lot of jumbles of letters and numbers in here, and I'm sorry for that. That's just how they geneticists like to name things based upon the mutations and the areas on the genome where those changes occur. But if you look, you could see that we had very high levels of BA.2 and BA.212.1. Those were all hot really in the spring and summer of 2022. And so the typical order that we've seen, so we start, with kind of BA.1.1 in our Omicron development has been BA.1, BA.2, BA.4 and 5 kind of came in next, and then BQ, which is really when we're getting into like the XBB variant. We're moving in that direction. We don't really see the hot one, which you'll see in the news, XBB 1.5, is not really super common in Michigan currently. It accounts for about 14% of tests that are coming in. They have not shown up yet. We have a backlog of samples that we're looking at for the last month. So we're waiting for the genomics data to come in on those. But we're at about 14% in Michigan, but a week ago it was at 7%. So these things move fairly quickly. When you look at this, you can see we have a lot of one-offs on different, slight different variations, but some of these are kind of binned into what we would call a BA.4 or a BA.5, and these are all just subvariants, subvariants of these subvariants. When you talk about the symptoms, right? So we all kind of recall what the symptoms were of I guess I can call it OG or classic COVID, right? There was the loss of smell, there was the upper respiratory infections that could get severe and turn into lower respiratory tract infections. That has kind of been changing with as Irving was mentioning, with the evolution of these viruses, right? You got to remember, this is not it's not conscious design, right? They're trying, all these mutations occur randomly through mistakes, or there's a propensity for mistakes to happen in certain areas of the genome, but they're generally happening randomly. And then if a mistake is produces a change that's sufficient to make that particular version of the virus be able to more readily reproduce when it gets to the next person, then that reproduction gives that particular virus variant an advantage over other ones, and it starts to crowd out the other versions. And so really what you're seeing here is efficiency of reproduction when we move from variant to variant to variant. And just to give you some general idea of the context of that, right? We know that XBB is moving really quickly across the globe. This particular COVID variant now is 63 times less likely to be neutralized by existing antibodies than the BA2 variant. It's also 40 times more resistant than BA4 and BA5 subvariants to neutralizing antibodies. So the idea that this is a particular lock, and we have antibodies which are kind of a key that hook to it. The similarity of the changes in that key and that lock are becoming more and more different, such that that key will not work that lock anymore. Those antibodies cannot connect to that virus to glom onto it and help eliminate it from your body, which is why people are getting reinfected. You might have gotten COVID, back in 2020. I got it in April 2020. I had the Alpha variant at the time. I got it again several months ago in October 30th. And the reason, and I had boosters, right? And I had my full vaccine course. I had 2 boosters plus an Omicron booster, and still I became ill. Now that doesn't mean you shouldn't be getting these boosters. The important point is that I had a very mild infection when I got my second infection. I was updated on all of my boosters, and I think it's really important for people to remember that even if they are not perfect, remember a vaccine doesn't make you fireproof. Think of it more as a fire suit. You can't just walk into a fire and just expect to be invincible. A fire suit will protect you from fire to an extent, and you will get singed, but you may not get burned up. So it's important to remember the idea of how these work. They're not perfect, but they definitely reduce severity and reduce the duration of illness. So
hey Jeff, while you're on that topic, can I ask a question? It's funny, you use the fire analogy. I like the seatbelt one, right? Like, we don't think seatbelts prevent car accidents, but we know that they help us stay safe. We had a question in the chat. Could you talk a little bit about what this means in terms of immune escape, right? Like, you've talked about this idea that these variants have evolved, and they have evolved in a way that they're less likely to be neutralized by antibodies. Like, how do they know? I think is kind of what the community wants to understand a little bit, right? Like, how does the virus understand how to escape?
So the virus doesn't understand how to escape. That's the main thing. There's these mistakes, as Irving was talking about, get introduced, and so these viruses come in different flavors. Think I don't want to get you off ice cream, but think of all these different ice cream flavors. They're all basically ice cream, but there's other things that are sprinkled in there, so their flavors are different. Certain ones are going to get caught by an antibody. With certain mutations, they might get caught. They might get partially grabbed onto by an antibody and eliminated. Other ones that have a sufficient number of changes or mutations just aren't recognized. I like to think of it more like, if we're getting into our analogies, I like to think of wanted posters, right? You think of, it's got a description, there's a face on it, and they're like, this is the person, and people are looking around trying to see if that's the person. But you put a hat on it, put a coat on it, put some sunglasses. It doesn't look the same. So the antibodies, when they're looking around for the thing that they're supposed to attach to, don't recognize the thing, and they just let it go by. And that's really what's happening in terms of immune escape. The antibodies are designed to look for particular descriptions, when we talk about the structural description of a virus, because of how they fit onto it. If it doesn't fit, it doesn't hold. If it doesn't hold, it doesn't get recognized for elimination by immune cells. If it doesn't get recognized for elimination by immune cells, your body has to re-recognize that, develop new antibodies in order to deal with that. So instead of you having a virtually non-existent exposure to a virus, if a virus comes into you that you've already have antibodies to, you might never have any symptoms, right, that you would notice. So your body sees that infection, grabs onto it, eliminates it, and it's done. The reason that you start to see that reinfection is it's new. Your antibodies get fooled because it's a different variant, and you have to go through that illness process again, generate new antibodies, and go through the elimination process. And in that process, you get sick, you get a fever, you start to show all of the symptoms. I think one of the other things that's important to note, which we've noticed over time, which a lot of people have, is that the location of this virus has moved from the lower in the respiratory tract really to the nose, right? So it's really focused on the nose, and it's in the saliva. And we even noticed that because we developed a saliva-based kit. And there was a lot of skepticism about developing that kit back in 2020. They were like, we don't know if it's going to be as effective as sticking something in the nose. We ended up showing that saliva concentrations were more sensitive than looking in the nose. So the idea that you're talking or coughing and saliva particles are getting out there is just a new method for spreading this virus, right? When a certain mutation produced a higher concentration for infections up in the in your mouth and your nose, that produced greater spread. That greater spread allows it to get to more people, and that's how that particular variant grows in the population around the world.
That's really, really super helpful. The other question we had that's sort of a follow-up, and I want to be sensitive to your time as well,
Absolutely.
is should we be worried about another variant like Delta coming in the future? And I think in context with some other questions I'm seeing, I guess if you could talk about, is there a way we expect viruses to evolve, and that are they likely to get more severe or more contagious, so to speak? And then should we be worried about something like Delta that was both super transmissible and had high likelihood of being severe?
Yeah, and if you want to jump in at any point, Irving, please do. But the idea, viruses are not, their goal is not to become more severe, right? Their goal is to reproduce, and that's it. So what we're seeing now is less severe illnesses overall, right? There are still severe illnesses out there, but that's a combination of people having successive exposures to the virus, and then also this virus evolving into something that produces something that it doesn't want to kill its host. It wants to spread itself, and so it's really focused on transmissibility. So we're seeing greater transmissibility. The reason we see immune escape is because that's the way a virus ends up elbowing its way into the top of the pyramid of other SARS-CoV-2 viruses by being more infectious and more virulent.
Yeah, and I think we like to think about the virus like a thinking person that make a decision to change and to be more infectious, and we need to switch that equation in our brain, because it's us, the one that are providing the surface, the mechanism, the vehicle for this virus to evolve. And it's just a selection process that we are giving to this molecule that only have 27 proteins. We have 27,000 proteins. We are a thinking organism. So we can control this by preventing infections, by if you feel sick, stay home. If you test yourself, avoid contact when there is large people, wash your hands, the same recommendations that we did from the beginning, because it's us, we are the vehicle that we are allowing these mutations to occur. And by selection, we are actually contributing to have other viruses that are more infectious. And hopefully, we don't gonna get to a mutation that is highly transmissible and highly and deadly, because that will be that will put us back in 2020.
Yeah.
But it's us, it's our behaviors, is we are the vehicle that are allowing this to happen. The virus doesn't have any idea, doesn't think about it. It's us that we are contributing to it.
I love that you brought it back around to what we can do, because I think that feels really important, right? We have had to figure out the different ways we navigate the virus that's still around. And I appreciated your advice around still being thoughtful, right? If you're in large spaces, you might, masking feels important. If you are, around people who might be immunocompromised, be thoughtful about that. Wash your hands, right? Stay home if you're sick. I think that feels like really, really prudent advice. In the last minute we have, there is one last question, and I want to be sensitive to Dr. Haggerty, who's coming up behind us. Someone says, I've had all my vaccines and boosters except the bivalent due to COVID illness. How long will natural immunity protect me? I think this is a great question because we've heard differing numbers with differing variants. So if you have any last thoughts on that.
You want to go, Irving, or?
Well, you can go ahead. Yeah.
Yeah. So I mean, it depends. I think that most people would say you're pretty safe within 60 to 90 days after exposure. Beyond that, it really depends on what your antibody response was, and we don't know what your particular neutralizing antibody account was. We don't know the circumstances from the last time that you either were vaccinated or had an illness. So everyone's different. Generally people, but it's not unheard of to become reinfected within 60 days. It can happen, particularly if you're immune compromised or older. But you shouldn't never think of yourself as, oh, now I have a free period now where I can do anything I want and be careless. You should always be sensitive to that. And there's nothing worse than a surprise of a once again a reinfection within several weeks afterwards. I've known people that have had it. They thought they were safe, and then they got it again. And these are people who know better. So
and usually the information that is shared by the scientists that do this experiment to measure and all that is an average.
Yeah,
it's an aggregate. Mm-hmm. Some individuals may have less time, other individuals may have even longer, depending on your physiology, depending on your metabolism. Everyone is different. So, but what the number that you hear is the average, is what in the group that have been studied. That's 6 months, 12 months, it depends, but each individual will have something different.
All right. Thank you so much for your expertise. Welcome to stay around in the background in case we've got overlapping topics with Dr. Haggerty, who's up next to talk a little bit about her amazing work with the Flint Registry and what COVID has meant for the Flint Registry. So thank you so much, Dr. Haggerty.
Well, good afternoon, everyone, and I hope everyone is feeling well today. It is a lovely, dreary Friday afternoon where I am. So I am not going to dive into the mechanics of the virus or talk much about infection risk and things like that, which are typical of my training. I am an epidemiologist, but I am going to talk a little bit more about the impact from maybe a little more social perspective of COVID-19 on our Flint Registry participants. Now, if you haven't heard of the Flint Registry, I want all of you to write down my email at the end of this and email me about getting involved. But if you have, excellent. The Flint Registry is a surveillance system that was designed to support individuals who'd been exposed to the Flint water crisis and keep tabs on what's going on health-wise with our Flint community as recovery is ongoing. So again, I'm Diana Haggerty. I work for the Pediatric Public Health Initiative and the Flint Registry here at Michigan State University in Flint. So the questions we asked to get at impact of COVID happened at our 1-year follow-up survey. So if you took a baseline survey for Flint Registry, wonderful. We closed our 1-year survey in July. So if you're just coming up on a 1-year anniversary, you won't see that. But if you had signed up for Flint Registry before July of 2021, you would have gotten an invitation to take the 1-year follow-up survey. In that survey, we asked 8 questions about how COVID has impacted both individual and family level aspects. So I'm looking at adults here. And those 8 questions had answers that ranged from not at all, or even in some cases, things have gotten a little better since the onset of COVID, to ranging there's been a lot of impact. So questions like, how has the coronavirus pandemic negatively changed your routines? How has it impacted your family income and employment? How has coronavirus pandemic impacted your level of stress? So we assess the total impact of these 8 questions by assigning each of the scores a numeric value. So if you said has the coronavirus pandemic negatively changed your routines? Not at all. You would get a score of 0. If you said, oh yeah, it impacted my routines a lot, you'd get a score of 3. And then, so those scores are then summed across all of the 8 questions. And so you could end up with a total impact score of -2 ranging to 24. So when we look at total impact, there's this, you see that COVID-19 pandemic has impacted our Flint registry participants pretty substantially. 50% had a modest impact score, so their score ranged from about 1 point to 8 points. About 35% reported a moderate impact, so 9 points to 16 points, and about 10% reported a high impact. So most of our participants reported some sort of impact. This doesn't tell us a lot, though, about what aspects of COVID-19 are being impacted the most. Or what aspects of life are being impacted the most by COVID-19. So when we break apart these 8 questions, if we look at stress, we can see that individual stress levels have changed a lot for the negative during COVID-19 for our participants. About 35% of our participants reported a small increase in individual stress level. Another 30% reported a moderate increase, and about 25% reported there was a substantial increase in their individual stress levels. Now, this doesn't seem to bear out for family stress. Almost 50% and 45% of our participants say that their family stress levels haven't changed at all, which I think is kind of an interesting thing that we need to dig into a little more. However, still about 25% are reporting at least a little stress has increased in the family. When you think about our sample size, which is over 5,000 people, that's a lot of people ultimately. And then some and a lot, if you stacked all those bars together, you'd see about 60% of our sample is reporting that there's been some family stress level changing. Impacts on connections and routine. When we think about family connections and other non-familial supports, it's really concerning to me that we see most of our participants, we're looking at about 75% of our participants, are reporting some loss of connection with family or other support systems. And it's also really interesting to me that it's a pretty stable distribution. It's almost 25% across the board. Our routines changed a lot, and for the worse. So I would say this is the highest bar I saw for any of the ALOT question or the ALOT answers at about 30%. So we know that COVID is impacting our participants' routines substantially. When we look at changes in employment and income and changes in food access, so how you're managing your finances, how you're able to feed your family, unfortunately not seeing quite as much impact as we are in other aspects, but there's still a substantial, again, we have a big sample size here. It's a substantial number of people who are experiencing changes in employment where COVID is making these things go down. It's about 40% of our sample see a decrease to some degree in employment or income, and then some food access is reduced as well. So it's a long way of saying COVID has not been easy on our community. Finally, if you look at impact on care access, if we asked if COVID has changed access to medical care, my initial reaction to this slide was like, oh, that's great. People aren't seeing changes in access to medical care or mental health care to the degree that we're seeing other impacts of COVID. But this could be a double-edged sword as I put a little more thought into it. And this needs more investigation. And this slide really makes me wonder is if, the rosy side would be people are getting access to medical care and mental health care access. And that hasn't changed as the result of COVID, but the other side of it could be that people aren't getting these things to start with, and COVID's not really impacting it at all. So there's more research to do on the impact of COVID in our Flint community. The Flint Registry is thinking about that, working on that, and that sort of thing. So my brief conclusion is that COVID has overall had a modest negative impact on our Flint Registry participants, but we see that there's variation in that impact. And I'm particularly interested in individual stress levels, access to family and non-family supports, and then changes in routines. So again, thank you. If you are excited about the Flint Registry and want to learn more, feel free to reach out to me. But yeah, that's what I've got for you, and I'd welcome questions.
Sorry, thank you so much. You'd think after 100 times you'd remember how to unmute. I want to see if Nurse T and Dr. Gordon are still on, because I think your presentation is so community-based and so based in what the community is experiencing relative to COVID. And I just want to ask Nurse T and Dr. Gordon about how this dovetails with what they've seen in the community and what they're hearing from the community.
Okay,
There we go.
Let's see. Oh, yes, this is tying right into what's going on in the community. We just had a discussion with some of our seniors, and they were asking about the vaccination and the different, we're talking about the different, the variants mutating and how it's going to play out with continuing with being vaccinated. We are still in partnership with the Genesee County Health Department doing vaccine clinics and education. So we're still with our hands on the pulse of the community and out there in the streets providing up-to-date education and resources on the impact of COVID in our community.
Definitely, thank you. Nurse T, did you have any thoughts?
I agree with everything that Dr. Gordon said. The stress and of COVID, and then all of the signs and symptoms of things that have occurred after COVID is a lot of people are saying now, especially with the vaccination, making sure that we continue to stay active, stay visible, and stay present. Because now we're hearing community residents saying that they received their vaccination, not knowing some of the side effects of heart attack, which really increases the importance of making sure that they know the signs and symptoms. So it's just a lot of continued conversation, continuing to encourage and empower the community to be responsible for their health, and to understand why it's so important that we all work together to have the information that's accurate to make wise decisions and not get caught up in blaming, but seeing what we can do to become better individuals of health for ourselves, because we're always going to have side effects, but do the side effects outweigh the benefits of not being in the hospital or not having that extra layer of protection?
I really, really appreciate that you made that point, because in like a minute, we're going to try to tackle, and we'll bring it back so that you get a full and robust answer to this question. But someone did ask about the link between vaccines and stroke, and closely related would be those heart attacks that you mentioned. And where I will leave it, I appreciate that Dr. Vega answered this question in the chat before leaving, and said that he didn't see the most recent data at the CDC suggesting an increase in the risk of stroke. What I think is important to leave people with is exactly what you said, Nurse T, is everyone has to make that risk kind of ratio for themselves. The risk of COVID, we know, is significantly associated with things like blood clots, stroke, cardiovascular complications. And so we absolutely know that that risk is super high. And we've seen no association thus far that the risk of vaccination even closely approximates that. So those are the things we need to be considering, and having conversations with people like Diana, Jack Lipton, Irving Vega, all of you wonderful experts, and including people in the community like Dr. Gordon and Nurse T. So we're super thankful to all of you here who have lent your expertise to our community, and certainly will be remembering the things that we talked about today. And we'll try to get you more information about some of the things that you've asked questions about today. Always want you to invite your colleagues and other organizations to take part in this webinar. Thank you to our partners. You see all of them there. I couldn't possibly list them all or thank them all without forgetting any, but thank you so much to our wonderful partners. And we will end with our weekly reminder of how to get those continuing educational units for community health workers. Thank you so much for your attention and your time, and we'll see you next week.